Well, welcome everybody. It's my absolute honor and pleasure to be here with you. This month actually marks my 10th anniversary here at the University of Chicago Medicine. And as I reflect back on this journey, I think about what we were telling parents with HIV as they were giving birth and even before the birthing process about their options for infant feeding. And the amount of data and the amount of change that I have seen in this domain over the past decade has been enormous. And I look forward to sharing with you some of the guidance and the recommendations that have come forth in recent years, which really focus on shared decision making with parents with HIV who are curious about breastfeeding and maybe in a good position to do so. I'm also hoping to leave some time at the end for questions and answers. In terms of disclosures, I'm willing to accept financial disclosures if anybody is willing to give them. I have none. But the couple of disclosures I do want to make is that I am a member of the committee of the American Academy of Pediatrics, which authored the referenced clinical report. As Donna stated, I'm also a member of a DHHS panel, which also publishes guidelines annually, of which infant feeding is a big component of those. You may leave this particular session with more questions than answers. I want to let you know that that is absolutely normal and expected. And I'm willing to continue the discussion beyond today for those of you who are interested in doing so. And I also just want to put it out there that I am aware that there will be some updated guidance released on this particular subject in the coming months. I am not at liberty to disclose that as of today, but want to let you know to keep your eyes peeled because we are constantly talking in this community about ways in which we enhance and strengthen our recommendations and guidance for providers in this arena. I won't go over the objectives as Donna already did that, but we're going to review the report, we're going to cite data, and we're going to talk about how we approach management of infants who are born to persons with HIV who are breast and chest feeding. And I will say that I will probably utilize the term breastfeeding most often throughout the presentation, but please understand that in the spirit of inclusivity, I am, basically including those who are also chest feeding. And so, as I think about this particular clinical thing that comes up, right, in the context of visits, right, I'm thinking about a patient who, is of childbearing age, female identified. They're coming into your OB clinic with a known diagnosis of HIV, and this is just kind of routine follow-up prenatal care. She's currently at 28 weeks of pregnancy and really wants to know about infant feeding options. And so as we're kind of thinking about being approached with this question, what are those things that are really important to consider in this scenario? And I'm, in the interest of time, not going to have you unmute and share, but I want you to kind of keep this in the back of your minds as we progress throughout the hour together, because I'm going to circle back around to this, and I'm then hopeful that we'll stimulate some discussion about the things that we should be thinking about when someone comes to us with this question in the clinical setting. And I think an important place to start here is in the United States, how many persons with HIV are delivering yearly, right? And if you look at CDC data, if you look at data from the American Academy of Pediatrics, this number is a bit of a moving target, right? We would guess that up to 4,000 persons with HIV deliver infants each year here in the United States. And about 75 to 85% of those have an HIV diagnosis prior to pregnancy, which is fantastic, but there are still 15 to 25% of individuals who are unaware of their HIV diagnosis. And as many of you are aware, that is obviously one of the higher risk scenarios in terms of parent-to-child transmission of HIV through the perinatal route. So while this topic of conversation will not focus on screening, we understand that, especially in the state of Illinois, right, we are doing first trimester and third trimester screening in an effort to close this gap, in an effort to ensure that all persons who are pregnant know their HIV serostatus going into delivery. I will say that this 3,000 to 4,000 number, depending on the source that you read, can cite up to 5,000. So there are a significant number of individuals who are delivering infants who are living with HIV. We are witnessing in our clinic, anecdotally, many of our youth with perinatally acquired HIV growing up, becoming of childbearing age, and are having uninfected infants themselves. So this number is only going to be expected to rise over time, given the fact that people are now receiving so much in the way of life-saving antiretroviral therapy. And I'm going to take you back to a period of time that some of you may remember, some of you may not. I don't remember it from an HIV perspective, but HIV, as we all know, was discovered and named in the 1980s, in the early 1980s. And at that time, there was very little known about HIV. There was very little known about how it was transmitted, right? For a while, it was thought to only be a disease that impacted men who have sex with men, and we quickly came to find out that that was not the case. But because scientists and clinicians did not know exactly how to prevent this from happening, the recommendation was that there should be no breastfeeding, that there was no ability for a person with HIV to breastfeed their infant on account of concern for transmissibility. But this didn't look the same in the US as it did the world over, right? And other places in the world, and I learned this a lot when I was in Botswana, is that in order for formula feeding to happen, it needs to be available, it needs to be accessible, it needs to be safe, it needs to be feasible, it needs to be accepted by the individual who is going to be doing it, right? All of these criteria need to be met in order to essentially utilize it as a safe form of infant feeding. And the World Health Organization, for many years, has recommended breastfeeding through 1 to 2 years of age in the context of antiretroviral therapy for the breastfeeding parent and or prophylaxis with antiretrovirals for the infant. So already sort of hinting at this notion, right, that if we have good virologic control, which is the goal of HIV for persons with HIV, and you have prevention methods on board, that we should be able to minimize risk considerably. And now the United States has caught on and has started to say that for patients who are eligible, and I'll talk more about that in a little while, that breastfeeding is welcome here, that breastfeeding should be something that is discussed with a birthing parent with HIV. And the CDC, in addition to the NIH and Department of Health and Human Services, have all really united around this idea of discussing infant feeding practices. And this is because the times are different now. We have highly active antiretroviral therapy. We have an uptick in the number of women who know their diagnosis, or persons who know their diagnosis prior to birth, who are on long-term antiretroviral therapy. So we are able to say that there is much more confidence that those people who have virologic suppression would be able to safely breastfeed. And so the first time that this was actually put into recommendations was in January 2023, when our group came forward and said, this is the data to support the idea or the notion that breastfeeding in persons who have virologic control of HIV is possible and is able to be safe. Likewise, in June of this year, so just a few months ago, my colleague, Dr. Lisa Oboji, who is out of Colorado, spearheaded this clinical report for the American Academy of Pediatrics, looking at infant feeding for persons living with HIV, in the United States, and what the data was around supporting persons with HIV with respect to their choice for infant feeding. I want to be incredibly clear about something, and I think it's always important to go back to this, and that's why I've dedicated a slide to this unto itself, is that for people with HIV in the United States, avoidance of breastfeeding is the only infant feeding option with a 0% risk of HIV transmission. And we're going to talk about this throughout the presentation. This is the official American Academy of Pediatrics stance, is that there is always going to be a minimal risk, a small risk with breastfeeding with HIV. And the only way to avoid it completely is, or the only way to avoid that completely is to avoid breastfeeding. And so this is something that's imperative to ensure is included in our discussions with parents with HIV who are wanting to learn a little bit more about infant feeding options. I want to talk a little bit about the Well Project, and some of you may be very familiar with their work, but they are a nonprofit organization based out of Brooklyn, New York, who are really focused on women and female persons, female identified persons with HIV, and how do you support women and empower women, especially through their reproductive years, in terms of breastfeeding, in terms of obstetric management, all of these different things that face women uniquely, they are on board for. And I will tell you that one of their representatives actually sits on the DHHS panel alongside us physicians to help us bring community into the work that we're doing. It's essential. You cannot do this work without including community's voice. And the Well Project seeks to uplift and amplify community voices, which is incredibly important. And they conducted an infant feeding and survey report with respect to HIV this year. And I'm going to share some data. What did this look like once recommendations were released and guidance was released around healthcare provider support? After these guidelines came out in 2023, what did that look like? And if you can see here below, prior to the report, about 32% or a third were mostly or very supportive. But after that, we had nearly a 50% change, going up to 82% in healthcare providers being mostly or very supportive after the release of the 2023 guidelines. Some of the responses that they got were, the guidelines are our first large step. Obviously, we need additional work around this to provide tools to support these sort of conversations and the communications that are taking place. Another person noted that before this, the conversation was a little stickier and the conversations were a bit more off record, right? It was more of a stigmatized discussion, but now there is actual clear support and guidance. And while it's imperfect, it's a start and it's something that we anticipate will continually evolve over time. And one might ask, who are the people that are being surveyed by the Well Project? Well, it's really exciting because you can see from the numbers below that everyone from social workers and therapists to medical doctors and all those people in between who are so important to these particular efforts were surveyed. And I thought it was really interesting that, when it came to the doctor piece, that over 50% were infectious diseases, but then right behind were pediatricians. But we have great representation from so many fields. And again, this is a conversation and a topic that can span many different disciplines in medicine. So very important to ensure that we are asking people, not just in ID, not just in OB, but across the board in different medical specialties. And again, another kind of healthcare provider respondent is, they're noting that it's important for these providers to put decision-making power back in the patient's hands, because this is how we avoid stigma. And, providing care to youth with HIV on Chicago's South Side for the last 10 years, I cannot tell you how much stigma comes up in our daily discussions. It's impacted disclosure. It's impacted adherence. It impacts lives in so many ways that I never even imagined when I first embarked on this journey. And so destigmatizing this condition is essential to getting buy-in from patients and buy-in from providers, and to ultimately providing the best care that we can. And I'm thinking about another example of this. Back when the WHO announced that dolutegravir, a commonly used antiretroviral in pregnancy, was going to be, utilized for women as first-line therapy for HIV during pregnancy, they noted that there may have been an above background incidence of neural tube defects associated with this particular drug. The long-term data showed that there was not any kind of noise above that which would be expected. And so they ended up taking away that guidance or black box warning. But what I will tell you that happened in community was that women said, we understand this risk and we accept this risk, but because it's a once a day medication and it helps me be adherent and decrease the chance of transmission to my baby, I want to take that and I need to be a part of the conversations that are deciding what is best for me. And I think that this is another example of that type of self-advocacy that is so important. And then, another one saying, we're past the time where we need to tell parents how to feed their children. We need to provide them with the risk and benefits and help them to come to a decision and make the best choice for their families. So then what is the risk, right? What does the risk look like in this particular situation? Well, we know that 30% of perinatal HIV transmission can occur from breastfeeding. However, this data is essentially data that was collected in the absence of any antiretroviral therapy for mom or baby and the absence of viral suppression. And we know that the risk of transmission is going to be highest in the first 4 to 6 weeks of breastfeeding, with around 5 to 6%, which then declines to 0.9% per month for the duration of the feeding thereafter. A lot of people will ask me, well, why is this? And I don't know that anybody has a definitive evidence-based answer for this, but obviously, all of the different biochemical changes that are occurring in the mammary glands, milk production, engorgement, inflammation, right? All of these kind of natural physiologic responses, one could posit would lead to higher risk of transmission when breastfeeding is initiated. And then over time, as cells remodel and things change and kind of stabilize and settle out, this does decline over time. We know based on our data that there is higher transmission in persons who acquire HIV during lactation. And it would just make sense that those with a higher HIV viral load and lower CD4 counts, which are more characteristic of advanced stage HIV, would be more likely to transmit virus from parent to child during breastfeeding or chest feeding. So there are so many questions. And as I said, you're probably going to leave here with more questions than answers. But there are questions around, what about a long duration of breastfeeding? What about mixed feeding, right? Which is commonly thought of as the introduction of formula or foods in addition to breast milk before the 6-month time period. After the 6-month time period, the American Academy of Pediatrics says that that's more complementary feeding, so that would not be inclusive of complementary feeding. What about mastitis? What about if the infant develops oral thrush, or what if the parent has nipple cracking or bleeding? And what about abrupt weaning? So there have been many, many thoughts about all of these things causing an increased risk of transmission. But one of the things that we have to remember is that we don't have studies about this when the breastfeeding parent is receiving ART and has achieved virologic suppression. So most of the data that came from studies looking at contributors to perinatal transmission through breastfeeding, those individuals that were looked at were not receiving ART and did not have virologic suppression. And now that, again, these things are so widespread and uptake is robust throughout sub-Saharan Africa, we have room to grow, but there's still robust uptake. It's a very different clinical picture. So in the setting of ARVs, right, we know that studies in both high income and low middle income countries that are looking at parental ART and or infant prophylaxis with antiretroviral therapy in the setting of breastfeeding, we have seen less than a 5% transmission risk and less than 1% among those who have achieved virologic suppression. So sort of all of this data is pointing us toward the fact that less than 1% risk among those who are breastfeeding and have achieved virologic suppression. I'm not going to go into detail with clinical trials today, but one of the trials that I encourage you to look at if you are excited and want to think a little bit more about the work that has been done around this within the last decade or so, the PROMISE trial, which is an impact network study, formerly the Pediatric AIDS Clinical Trials Group, conducted the study in 6 African countries as well as in India. And they essentially looked at antiretroviral therapy in persons who were breastfeeding versus giving infants prophylaxis with one single antiretroviral. And they looked at the time period through 18 months of age or whenever breastfeeding was cessation occurred, if they were weaned earlier. And no matter what they were looking at, whether it was this maternal ART or daily infant nevirapine prophylaxis, they were both found to be equally efficacious and effective in preventing HIV-1. And transmission risk was only 0.3% at 6 months of life and 0.6% at 12 months of life. And this was one of the defining trials that really showed us that either or could be sufficient. Are both better? We're not quite sure. One of the things that I want to make sure I comment on is this idea of U equals U, because I have a lot of patients who I talk to who are incredibly cognizant of this campaign and will say to me, Dr. Rosebush, but undetectable equals untransmittable, right? And I will say, yes and no. It depends on the context in which you're asking, because certainly in the context of sexual transmission from a serodiscordant couple, from a positive partner to a seronegative partner, yes, that is true. We've had hundreds of thousands of serodiscordant couples in which the individual with HIV was on virologic or on antiretrovirals and was virologically suppressed. There were no incidents of transmission. But unfortunately, though this is so empowering and should be talked to every single person with HIV about, we should be talking about this to empower them. This is not the case when it comes to breastfeeding. And we have reports that even with virologic suppression, there are very rare instances in when transmission can occur. And there are many theories as to why this is happening, and there are people who are actively studying this. So is there some low-level detectable RNA in human milk, despite what we can measure in the plasma? Let's remember, right, even when I'm getting plasma viral loads on patients, I know that there are reservoirs in the gut-associated lymphoid tissue. I know that there are reservoirs in the CNS, that this is an in-the-moment snapshot of what's happening in the body. And the blood doesn't necessarily represent every other body compartment. Are there parental immune cells that are harboring some provirus, some DNA provirus that could establish infection? And as I already mentioned, right, are there viral reservoirs, so not just in the central nervous system, not just in the gut, but in the human milk that for whatever reason, ART is unable to eliminate? These are some of the leading theories as to why U equals U doesn't really apply to breastfeeding. But on the flip side of this, for the longest time, even before these guidelines were available to providers, parents with HIV want to breastfeed. And why do they want this? They don't want to hurt their infants. I have a very, very hard time believing that there is a parent who says, well, of course, I want to harm my infant. That is not the agenda. That is not the MO. They may want to bond with their infant and find that this is a way to bond. They may know about the incredible health benefits that are bestowed upon an infant who is able to receive breast milk. There may be cultural expectations. This one, I have to say, comes up all of the time, especially in immigrant populations because of the cultural context of breastfeeding. It's almost as if that's a disclosure if family or friends see somebody with HIV who is not, or see somebody who is not breastfeeding, that may connote a diagnosis of HIV in that person, and they want so desperately to avoid that. That also then feeds into, again, like I said, these disclosure challenges. And we know that there are benefits to the breastfeeding person around the actual process of breastfeeding. And we see exaggerated health disparities in communities of color. And because we know communities of color are disproportionately impacted by HIV, not giving them an opportunity to breastfeed if they are a good candidate may exaggerate other things, cardiovascular disease, hypertension, mental health, concerns, those sorts of things that may be remedied by the breastfeeding process in and of itself. So when it comes to recommendations, I know that I told you before, and I'm going to revisit this again now, is that avoidance is the only way to ensure 0% transmission of HIV. And before I kind of jump into counseling, I talk about the barriers to alternative methods of feeding. Is there a barrier to formula feeding? Is there a barrier to donor breast milk? What are thoughts and feelings about those alternative methods of feeding? But if the person who is in front of you, who is saying, no, you know what, despite this, I absolutely want to explore what breastfeeding would look like, then the thing that we need to do is counsel, counsel, counsel. And so far, the way that this has looked at UChicago Medicine is that we have employed a multidisciplinary team model with adult ID, pediatric ID, maternal fetal medicine, lactation, nursing, social work. I didn't list everybody here, but these 4 kind of core services are the ones who typically get involved initially. But I'm going to talk about this a little bit later on, and that I want to think more about how we formalize a workflow around this. We talk about the potential risk of transmission throughout duration of breastfeeding. And then there is an option for assigned agreement, which I have actually not done with patients, but has been proposed by one of my colleagues on the DHHS panel. She is a very experienced obstetrician at Baylor in Texas, and she had come up with this for her patients. This is not a contract. This is not something that is meant to be punitive. This is a reminder, because the conversation is so nuanced, and a lot of information when we go to the doctor, right, goes in one ear and out the other. When we're seeing the provider, we're really not processing all that's being told to us, especially when it's an emotional conversation. So this is for the patient as a way to sort of remember what those things are that they need to do. So bring my baby for HIV testing. If I develop a breast infection, how do I approach that? I need to have consistently undetectable viral loads prior to delivery. It's a way to just reinforce the things that we feel are incredibly important for patients to know and to remember in order to do this safely. And who are we doing this for? We're recommending, or not recommending, but we're supporting persons who want to breastfeed and whom they have had early ART initiation, either before pregnancy or early on in the course of the pregnancy, that they have sustained virologic suppression, which is really defined now as less than 50 copies per milliliter in a plasma assay, that they have demonstrated a commitment to taking their own ART, which would be the case if they're suppressed, and to giving infants their prophylaxis. And we work with families on how to administer prophylaxis. And then we also want to, as best as we can, ensure uninterrupted ART access, making sure insurance is valid, making sure that if it's not, that we have another way to get medication to them, so that in the midst of breastfeeding, they don't find themselves without antiretroviral therapy, posing a risk to the infant. And so some strategies for providers are exclusive breastfeeding for the first 6 months, if that is able to be done. As a parent myself, I can say that that is a very hard thing to do. And so this may not be possible for folks, but we should be talking about it. Continuous ART for parent, again, that has sustained suppression, frequent monitoring. So one of the things that I think has been a barrier in the conversations I have had is the frequency with which parents are needing to have viral loads drawn. Typically, in traditional care, it would be every 6 months or 12 months, depending on who they are, maybe as frequently as every 3 to 4 months, but this actually requires monthly monitoring. It requires infant ARV prophylaxis in many instances, and then gradual weaning over 2 to 4 weeks. We don't want to wean abruptly in these patients. And so what have been some obstacles that the Well Project has found in terms of, considering feeding decisions? So, do we have culturally responsive educational resources? Are there people on the care team who may be a bit worried? I can't tell you how many people who I think are amazing providers, tremendous providers who have come up to me and said, this makes me really nervous and I don't know that I can fully support it. And so then we have conversations around it. So lack of support doesn't mean that they're not trying. There was this paradigm for decades before we finally said, okay, it's time to have this conversation and put the data out there and make some recommendations. So I completely understand that. And then I think the other part that we can really kind of focus and hone in on as a medical center, right, is explicit policies that support this. How are we making a coordinated effort as a medical center, as a perinatal network, to really ensure that all the people and pieces are there to kind of keep the momentum moving forward? How can you support non-judgmental discussions, providing the options? It is not supposed to be an influx of judgment. We really want this to be, these are the options. Evidence-based information. We want to ensure that what we are doing is as data-driven as possible, and making sure that everybody is in alignment, that we don't have a single person on the team who is not supportive while the rest are, because that can send mixed messages and be very confusing for a patient. And so I'm going to share something with you that is very challenging, especially as a pediatric infectious diseases specialist who tries to do everything with an evidence base, is that we know that the parent needs to have antiretrovirals, uninterrupted access, and ensure that they are virologically suppressed in order to minimize risk. But what is the data on ARVs for infants? There is no expert consensus on this. We cannot reach consensus because of the lack of data. So some are going to recommend extended ARV prophylaxis, which means that you get the traditional 4 to 6 weeks of AZT, but then after that is completed, you transition to a single drug for the duration of breastfeeding. And when breastfeeding is discontinued, you continue it for 6 weeks after the last event. As you can imagine, this raises a lot of questions. A lot of parents are like, I don't want to give my child a drug for, an additional period of time that I'm breastfeeding. What are the side effects of this drug? Why do I need to continue to give my child antiretrovirals despite the fact that I'm taking antiretrovirals and I'm virologically suppressed? Didn't that study show, right, that it could be either or? It didn't have to be both combined. And I can tell you a little bit about why some experts recommend the addition of the nevirapine daily. And because there are known toxicities, right, we do generally recommend some additional lab work. I will tell you that infants tend to tolerate this incredibly well, and so we don't see many hematologic or liver derangements in terms of our lab results, but we want to be cautious of this. The current state of Illinois guidelines, right, at the HIV pregnancy hotline that I help co-author alongside Lurie Children's, is that, as we noted before, we administer the zidovudine for 4 to 6 weeks, and then we do recommend the nevirapine. And the reason why we recommend this, right, goes back to what I was saying before about viral load suppression. We know that the viral load is a snapshot in time, and that there may be periods, even in the person who takes Antiretrovirals as faithful as they can. There may be missed days. There may be missed doses. Viral blips can occur and can pose risk, right? When you go above that 50 copies per milliliter, it is very important to understand that there is an increased risk. We are not seeing enough transmission events to be able to do a randomized controlled trial sort of assessing what the risk is. And so it can be very, very difficult to do this. And so our group, composed of people from all across the US in all different disciplines, could not arrive on a consensus with respect to the addition of nevirapine. And that, again, is something that is important to talk about with patients, but is something that we are currently recommending here. If and when we have somebody who is interested in breastfeeding, we incorporate that into the discussion. This is just a kind of an overview of when we are looking at the infant's blood. We are usually doing these at birth, though technically the guidelines are saying we don't do that first screen until the 2 to 3 week of life mark. But then we are doing this as we would for any other infant, 1 to 2 months of age, 4 to 6 months of age, and then doing every 2 months throughout lactation with some guidance for when we would want to repeat assays, after the weaning. And so again, this is additional lab draws. And there are some parents who have said to me, I don't like the additional medication. I don't like the additional lab draws for myself and my child. This is making it actually harder for me to breastfeed. So I am not going to do this. So, you've got some people who have very, very specific feelings about the increased surveillance that's required. And so what if the parent isn't an ideal candidate for breastfeeding, right? Intentional exposure to harm, as I mentioned, is not typically the agenda. There needs to be intensive counseling. I have encountered this here. Need to do as best you can an explanation of the risks and sort of what transmission looks like, and that we don't have a great idea or an exact percentage of what transmission is going to look like based on the current viral load. We just know that it's above baseline risk and is not the population that has been studied to be ideal candidates for breastfeeding. The one thing I want to point home to you, and is a big part of these guidelines, is that we want to, though, avoid referrals to CAPS or DCFS in this case. This is not cause for a referral and can actually fracture the relationship, as many of you can probably imagine. So what I want to do is try to see if there are ways we can handle this internally so that we are not putting a parent in a situation where they are being called out for the desire to harm their child or are perceiving it as a threat to themselves. And so back to our case study, right? How do we counsel this patient? 27, HIV, presenting for follow-up care, 28 weeks pregnant, and wants to know about feeding options. So how do we counsel this patient, right? What do we do for the baby? I think that there are a lot of questions that you could ask based on this data, right? How long has she known her HIV status? What is her viral load? Is she taking HIV medication or antiretroviral therapy medication daily? What are her thoughts about alternative feeding options, right? Is she a candidate or is she not a candidate? And sort of how do you lay out the different options that she may have access to in terms of feeding her infant? And so some take-home points before I move this over to some questions. We know that avoidance is the only method that fully eliminates risk when it comes to infant feeding. We know that those who have sustained virologic suppression and longstanding adherence to ART are ideal candidates to breastfeed. We know that antepartum multidisciplinary counseling is essential. I have been in a situation a couple of times where this question comes up as the patient is literally being wheeled out of the hospital, and I will handle those things, of course, but I think it's just not an ideal time for the conversation to be had, right? If it's possible to do it in the outpatient setting with a multidisciplinary team, that would be preferable. Don't contact DCFS. We can try and resolve these issues with internal resources. Oftentimes, what the key is here is extensive counseling and a better understanding on the part of the parent as to what constitutes risk. And then, as I said, these ambiguities around prophylaxing infants with antiretrovirals throughout the breastfeeding period aren't really going to be able to be answered through randomized controlled trials because there is already an incredibly low risk of transmission with viral suppression, as I've shown today. And so some future goals that I just want to mention is, developing an evidence-based multidisciplinary workflow at UCM that embraces shared decision-making around infant feeding for birthing parents with HIV. I don't know why it did that in the reverse, but I would love to brainstorm with folks and think more about this. But I also think we're not the only ones who don't have a solidified workflow. And so what are our partner institutions doing? What existing workflows do they have? Some places have been doing this for longer than the guidelines have said we should be. So there are people who are actually quite far ahead because they have already been doing this, given the data and the knowledge of the data. So these are a couple of the things that I would like to think about in terms of future goals for us here at UCM. And with that, I'm going to stop and I'm going to open it up for any questions, comments.
We have a question, Dr. Rosebush, that was placed in the chat by Kathy Cloninger. It says, how do real or potential shortages of ARVs or ARTs impact organizations' recommendations?
Yeah, so that is a really, really great question. And I think it's an important question, especially in the context of all of the various shortages that we have been faced with. Zosyn, penicillin for the treatment of syphilis, right? Metronidazole, IV fluids, blood culture bottles, right? We are seeing supply chain issues. The perinatal hotline and the network that is established within the state of Illinois, which I was blown away when I came here. I came from Georgia, where there was not a whole lot of statewide support for prevention of mother to child transmission initiatives. And when I came here and knew that we had a set of guidelines specifically for the state of Illinois, and that IDPH, the Illinois Department of Public Health, is really backing this and supporting this and ensuring that hospitals, including community hospitals, have access to a steady stream of prevention medication. That is really handled at the state level. So we really do have fail-safes in place in order to ensure that there are not shortages of drug. I have not heard personally of any potential shortages kind of down the pike or a path down in the pipeline. But I do think it's a very important thing to think about. But that I feel very confident in the way that the state has been ensuring that between them and the hotline itself, that they are ensuring that medical centers have ample supply of antiretrovirals for infants with HIV exposure.